Okay, so I decided that I would record the exam review for exam number 3, but I just want to caution you guys that this exam review does not have, it's not all inclusive. So what do I mean? I mean, watch this review, listen to this review, but also go back and listen to your lectures. Pull up your study guide, look at the chapters, look at the reading. So use all of your resources to study for this exam. So not just this review, but I thought that this review might help you to focus in on some areas. Okay? Okay, so we'll start here, no particular order. Just started with chapter 44, which is our pain chapter. So what I want you to know, nature of pain, all these bullets here on this slide are very important. Just remember that pain is always subjective and individualized. It's basically whatever that patient says the pain is, that's what it is. Okay, so if we talk about a definition, I think your book defines it as an unpleasant, subjective, sensory, and emotional experience associated with actual or potential tissue damage or described in terms of such damage. So pain, again, is purely subjective. No two people will experience pain in the same way, and then no two painful events are experienced in the same way. They create individual or non-identical responses or feelings in a person. And always remember that the patient is the one who is experiencing pain. So therefore, the pain is whatever that patient says it is. It's not the responsibility of patients to prove that they are in pain. It's our or the nurse's responsibility to accept their report. And effective pain management improves quality of life. It's going to reduce physical discomfort. It's going to promote earlier mobilization. We talked about immobility earlier. It's going to, if we can control their pain, then they're going to get up and moving sooner and then return to their previous baseline functional activity levels. And it also results in fewer hospital and clinic visits, and it decreases hospital lengths of stay, which will result in lower health care costs. Okay, so when we're talking about pain assessment, use the PQRST. This is also outlined in your text. And by the way, I'm not going to talk about page numbers here. I'll leave that up to you guys to reference the page numbers, whether it be old or new text. I'm simply just highlighting some information. And so this slide does talk about that PQRST, but always reference your book as well. So asking a patient about his or her tolerable pain level, that's our first step in helping our patient regain control. So determine what level will allow your patient to function also. Accurate assessment requires you to monitor pain on a regular basis along with other vital signs. And some institutions treat pain as that fifth vital sign. So pain assessment is not really just that number, okay? When they self-report pain, that can be our one most reliable indicator of its existence and intensity. That'll help us to understand where they are with that pain. Always ask them to describe too what activities might aggravate that pain. That'll give you a better idea. Is it with physical movement or positions, or we may zone in on a particular system like urinary system if they're having pain with urination, if they're having pain when they eat. So it can help us to understand what system we're working with as well. So it's always useful to know whether a patient has an effective way of relieving pain. That's what we want to ask them. When you've had this pain before, how did you relieve it? Find out what helps them. Meditating, praying, some of these things, non-pharm applications could be important here. So when we do ask them to qualify or give us a quality of their pain, you're going to ask the patient to describe the pain in their own words. Severity or symptoms. The purpose of using a pain scale is to identify pain intensity over time. so that the effectiveness of pain interventions can be evaluated. Some other symptoms that might go along with pain, I know some of us that have migraines can speak to this, so it might include nausea, or pain could cause them, another symptom would be dizziness, things like that. There are other symptoms that can go along with their pain that we need to ask about. So just make sure that we always assess any new reports of pain as well. Okay. Again, I'm not going over every detail. Just make sure you keep referencing your book on these slides. So pain's often unrecognized. A lot of times too, it can be misunderstood, and then that can lead to that inadequate treatment. So if our patients are having trouble telling us, what kind of pain they're having or what the intensity is, that doesn't mean that they're not in pain, right? So these are just some scales here that we can use with our patients to help us to understand what is their level of pain. Again, this is in your book. You can see these in your text. And these are just characteristics of pain here, the timing, location, severity. And also don't forget about our critically ill patients. They may have that clouded sensorium, or the presence of nasogastric tubes or artificial airways. They require specific questions that they can answer with a nod of the head, or either by writing a response. And so these pain scales that are on here may not be applicable for that. Okay, and then if we have someone that speaks another language, make sure we get that professional interpreter. Okay, so let's just talk a little bit about a PCA pump, or patient-controlled analgesic pump. Right here on the slide, it's going to tell you that it maintains that constant plasma level of analgesic. So that's what's really important about a PCA pump. So systemic patient-controlled analgesia traditionally involves IV or subcutaneous drug administration. However, a controlled analgesic device for oral medications is available. We've talked about this in your regular lecture video. So just so you're aware of that. They're portable, computerized, and they contain that chamber or syringe or bag that holds the medication. It's a preset dose of that opioid. Okay. The patient really does gain control over their pain when they use these, and pain relief doesn't depend on that nurse's availability, which is key here. Always make sure that you teach your patient this is for their use, not for the family or the friends to come in and operate that. Okay, so important points about that. Okay, very important terms on this slide. Make sure you understand the difference between physical dependence, addiction, drug tolerance, and then placebos. Remember that physical dependence, yes, if they stop taking the medication, and they do have this physical dependence, if they have that abrupt cessation, then they may definitely experience withdrawal. That's what I'm trying to say. It could include shaking, chills, abdominal cramps, joint pain, etc. Also, addiction, you're going to have your patients that will be afraid to even take medication because they're afraid of becoming addicted. So make sure that you understand that this would, one of the behaviors included in addiction would be like that impaired control over your drug use. So they would be using it compulsively. Even if it's harming them, they're just going to have that craving and not be able to stop. And then remember, drug tolerance is that state of adaptation where exposure to the drug, it kind of induces changes that result in a reduced, effect of the drug over time. Okay, so when we're talking about evaluation of pain, for our patients with chronic pain, the effect of the pain intervention on the patient's function should be considered when evaluating that patient's perception of his or her response to treatment. And then if patients state that an intervention is not helpful or even aggravates the discomfort, we need to stop it immediately and seek an alternative. Time and patience are very necessary to minimize the effectiveness of maximize the effectiveness of pain management. So educate your patients about what to expect too. For patients in acute pain, we're going to reassure them that you're going to check back frequently to assess for changes in pain level, and do continually assess if the character of the patient's pain changes and whether individual interventions are effective. When we're talking about evaluating the effectiveness of a pain intervention, that's going to require that you evaluate for change in the severity and the quality of pain. Also be sure to evaluate after an appropriate period of time. So what are we talking about? Very, very important that you guys understand that if we're giving an oral medication that's supposed to help with pain, we're going to check back in about an hour. Anytime we're given IV push meds, we're essentially going to see something happen with that, some kind of pain relief within 15 to 30 minutes. Okay? And don't expect the patient to volunteer the information. You're going to have to go back and reassess. Okay, our next chapter 32, and then for the new text, chapter 31. This is our chapter on med admin. Review your 6 rights. I always want to highlight this information when we're talking about a review for the exam, because important information to know, so make sure you go back and bring yourself up to par with the 6 rights. So when we're talking about maintaining patients' rights and talk about med admin, we want to talk about in accordance, with that patient care partnership. This is actually put out by the American Hospital Association in 2003. There are potential risks related to medication administration, so our patients have these rights that are listed here: to be informed about that medication, the name, the purpose, the action, potential undesired effects of the med. They also have the right to refuse the medication regardless of the consequences. So what do you do as the nurse when a patient does refuse a med? We must make sure that we find out the reason. Okay, we have to find out why are they refusing that med. Then when we find out why, we need to educate them on, okay, so if you don't take this med, this is what possibly could happen, this is what the med is for, blah, 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 kind of explain it to them. And then document that they refused it, and always, always, always notify the physician, okay? And just make sure you understand all these rights, reference your book, go back and take a look at all of that, okay? Okay, so we're going to go through this kind of quickly. It's just going to highlight, again, some of the things we've been doing in lab too. You're going to see some of these overlap from lecture to lab, obviously. So make sure, I'm going to say this just once, but it really is important for all of your exams to anything that we cover in lecture that has a yellow page associated, make sure that you understand those steps. Okay, that are associated. For instance, oral administration, sublingual, buccal, aspiration precautions, all of these are in your yellow pages. So reference those and go take a look at that. So sublingual, we obviously know that patient is supposed to keep it under their tongue for it to dissolve, or it will not have the same efficacy. It's not going to work the same if it's swallowed and such like that. Also, buccal, same thing, goes into the cheek. If it's swallowed, it's not going to have that same effect. So make sure that we explain that to our patient, that when we do put it there, that's where it's supposed to be absorbed, and they need to keep it there. Okay, topical medications. Important to use gloves. Remember we talked about nitroglycerin a little bit, that if you gave it and you accidentally got some on your skin, on your hand, through the application, then you're going to get the effects of that med yourself. We don't want you to have the same effects. So just remember, medications that are applied to the skin and mucous membranes generally have those local effects. Systemic effects often occur if a patient's skin is thin or broken down, the medication concentration is high, or contact with the skin is prolonged. So a transdermal disc or patch has systemic effects as well. The disc secures the medication ointment to the skin. That's how it's absorbed. These topical applications are left in place for as little as 12 hours or as long as 7 days, like some of our fentanyl patch or nicotine patches can be longer, up to that 7 days. So you apply that topical medication to mucous membranes through direct application of a liquid or ointment. Insertion of a medication into a body cavity, installation of fluid into a body cavity, irrigation of a body cavity, or you could spray the medication into a body cavity. Okay? So make sure you look at all these bullets and go back in your text and look at this area. This is a picture right out of your book, and this is one of those procedural, I don't think it's the yellow pages, but it is one of those procedural guidelines. Very important that you go and read this for the nasal, the eyes, the ears, okay? Those are coming up on the next slides, but go into your text and look at those. So the most commonly administered form of nasal instillation is that decongestant spray or drops. They're used to relieve symptoms of sinus congestion and colds. You need to caution your patients to avoid abuse of these medications because they could have rebound where that nasal congestion or whatever they're treating comes back even worse. Sometimes if we have severe nosebleeds, for our patients have severe nosebleeds, they can usually be treated with packing or with nasal tampons that are treated with epinephrine to reduce that blood flow. So it's not just for the drops. But you'll see how the head is tilted to get to the various sinuses. Excuse me. Eye installation. Again, this is a procedural in your book. Go and take a look at it. Medications commonly used by patients include eye drops and ointments, including over-the-counter preparation like the artificial tears and vasoconstrictors. Many patients, especially our older adult population, receive prescribed ophthalmic meds for eye conditions like glaucoma, or even after they have their cataracts removed. Age-related problems, including poor vision, hand tremors, and difficulty grasping or manipulating containers, affect that older adult ability to self-administer eye medication. So instruct your patients and family members about proper techniques for administering them. Determine the patient's and the family's ability to self-administer through a routine demonstration of the procedure. So showing your patients each step of the procedure for instilling eye drops can really improve their adherence. They're more apt to take the medication and keep on that regime if they can do it and feel confident about it. Medications delivered intraocularly resemble contact lens. So place that medication in the conjunctival sac where it remains in place for up to a week. Patients require teaching about monitoring for adverse reactions to the disc. They also need to know how to insert and remove those discs. Also, don't forget about with our eye drops, some have systemic effects that we don't want them to have. So make sure you're maintaining pressure on that inner canthus when you instill these. Ear installation. On this next slide, very important that we know the difference between the younger patient, younger than 3, and then the adult patient. This is also a procedural guideline. Administering ear medications is in your text. Very important to go and take a look at that. Because internal ear structures are very sensitive to temperature extremes, you need to instill ear drops at room temperature to prevent vertigo, dizziness, or nausea. If you've ever irrigated a patient's ears, you know that they can get very, very dizzy if we don't do that correctly. That temperature can make a big, big difference for them. So although the structures of the outer ear are not sterile, sterile solutions are used in case the eardrum is ruptured. The entrance of non-sterile solutions in the middle ear structure, that often results in infection. If a patient has ear drainage, be sure that the eardrum has not ruptured. Never occlude or block the ear canal with the dropper or the irrigating syringe. Forcing medication into an occluded or ear canal creates pressure that will injure that eardrum potentially. Okay, so parental medications, this is that insulin preparation. Just read these bullets on this slide and go back in your text and take a look. You've also learned in pharm about insulin. So just go brush up on the insulin and then on these bullets. And then mixing insulins, remember everything on this slide. Remember how we did that in lab. We can always pull in, questions from lab. So just make sure you understand these. You never mix insulin Lantus, Glargine, or insulin Levemir with other types of insulin. Very important. Also, what is the only insulin that we can give IV? Let's see, is it on there? It would be the regular insulin. Verify insulin doses with another nurse, always, okay? We talked about that in lab. And then don't mix it with any other medications or diluents unless it's approved by that healthcare provider. Most of all this is on your study guide, but just please make sure you're looking at this and your study guide and your book and your these chapters. Go back and review these chapters. Okay, so IM injections kind of went over in lab, also in the recorded lecture. What's important? Well, all of this is important. That angle of administration is 90 degrees. Remember that page I showed you from your text when we talked about this in lab. Also, adults, if you're going to give them anything over 2 mLs, it will tell you right here that 2 to 5, want to make sure that we're giving those not in those deltoids but in the ventrogluteal, okay? And then it also gives you parameters for the younger kids. Okay, and speaking of ventrogluteal, here are the landmarks. Please know these, and it tells you right there at the bottom, recommended for volumes greater than 2 mLs. And remember, when we're talking about IM injections, we do aspirate on our IM injections, except for immunizations. The CDC has told us don't have to aspirate on IM injections that are immunizations. Otherwise, you will aspirate. And remember, if you aspirate blood, you're going to start over. Okay, this is just another slide detailing how to find that ventrogluteal. Okay, intradermal. Yes, please review all of these bullet points and remember that famous question that we have in lab, that if you are injecting your medication, you're trying to give intradermal and you feel that resistance, that's actually not good because you are probably too deep for that medication. Remember, you're only going to go in that 1/8 inch. Okay, go back, take a look at that. Chapter 6. Lots of important information, but as far as like for the exam review, I do want you to know these phases, stages rather, of health behavior change. So this trans-theoretical model of change focuses on the stages of health behavior change. So these range from no intention to change, which is the pre-contemplation, considering a change within the next 6 months, which is contemplation, or making small changes, which is as preparation, and then actively engaging in strategies to change behavior. That will be action, to maintaining a changed behavior, which is that maintenance stage. Again, this is right out of your book. So our patients as individuals attempt to change in behavior. They can relapse, followed by recycling through the stages frequently. That does frequently occur. But when the relapse occurs, a patient will return to the contemplation or pre-contemplation stage before attempting the change again. Relapse is a learning process, actually, and people can apply the lessons learned from relapse to their next attempt to change. Most behavior change programs are designed for and have a chance of success when people are ready to take action regarding their health behavior problems. And then this is another slide that talks about that health behavior change. Understanding this process, by the way, of changing behaviors, that's going to help us support difficult health behavior changes in our patients. Actually, only a minority, usually about less than 20% of a population at risk, is prepared to take action at any given time. So action-oriented guidance misserves individuals in the early stages. Stress the importance of setting a goal when teaching lifestyle changes. Okay, so chapter 9, we're going to go over now. Again, very much important information in this chapter. However, with our chapter 9, which is our cultural chapter, we talk about culture in every chapter. So you may find it in the different chapters, not just in your chapter 9. Make sure that when we are talking to our patients about their culture, that if they are practicing any kind of folk healing or healing per their culture, make sure that it is okay. It doesn't really interfere with their medical therapy. If it doesn't, then we can help them with that. Spirituality and religion may affect a person's belief about health, illness, and end-of-life care. You can use several interventions to meet a patient's spiritual needs, including prayer, scripture, reading, listening, and referral. Communication refers to an organized, patterned system of behavior that may be verbal or nonverbal, so we need to be keen on that. Different patient cultures will communicate obviously differently, but not just with their verbal, but with their nonverbal as well. Some, don't like that eye contact, or maybe it's a female-male kind of situation that is defined per their culture. Okay. Chapter 25 we'll talk about next. So in chapter 25, it talks about teaching your patients. So this teaching process is similar to the nursing process. So let's look at what you need to assess. These are different things that we need to assess for our patients. We need to know, what are their learning needs? What are we trying to teach them? What don't they know? Where do we need to start our teaching? And then whenever we're evaluating our patients' teaching, talks about here on this slide, evaluation, talks about teach back. I know we've talked about that in class a little bit, but just make sure that whenever you are teaching your patient, the only way you really know if they understood, don't just say, did you understand? You guys know this, because they'll just say yes when maybe they didn't. Have them teach back to you, or to see if they are recalling that material. And I like to make sure that they understood what I was trying to tell them. We're not always the best communicators. We may think we're telling people what they need to know, but we need to see them teach it back to make sure that we have come across the way we want to. Okay, this is chapter 38, chapter 37 new. Okay, so I did put on your study guide that it's important to know those ego defense mechanisms. Go and find that in your book. There's actually a box that talks about examples of ego defense mechanisms, so pull that up. So that's just a way for our patients to cope. Coping is that person's cognitive and behavioral efforts to manage a stressor. No single coping strategy works for everybody or for every stressor. Um, you know, you can ask your patient about adaptive or maladaptive coping mechanisms. Maybe prayer would be something they're using that is an adaptive mechanism. Overeating would be maladaptive. Okay, so in stressful situations, most people use a combination of problem and emotion-focused coping strategies. And then these defense mechanisms, they help a person cope, and they help them cope with stress indirectly and offer psychological protection from a stressful event. Okay. And chapter 45 is our nutrition chapter. So let's just hit some of these high points. Developmental needs, yes, very important to know. Young, middle adult, some of the problems that they have there, those obesity due to that decreased physical exercise. Maybe they dine out more often. It's all about, you know, working and having, what do you say, convenience eating. And then always think about your older adult. We know that their taste sales, you know, decrease, so they may not can taste the food as well, and that's going to cause them not to eat as much. Anytime you have a patient that has poor oral hygiene, they're not going to be as hungry. So if we can help them with that oral hygiene, then we can help their nutrition. Okay, so this table 45-2, that's from your old text, but just the new one, just go and look for that drug-nutrient interactions. And you know, most of the time we want them to avoid grapefruit juice. Some of our medications, we can't have those things with them because it won't absorb properly. Okay. This slide talks about our vegan patients, our, you know, lacto-vegetarian. Tells you right here on this slide what they avoid, what they eat. This table 45-3, let me see if I can find, this is a very, very important table, so let me see if I can find it in the new text as well. Yeah, it's on page, well, it's still the same table, 45-3 in both of your textbooks. And in the new text, it's on 1110. I don't have the page number. Oh, yeah. Old text, 1063, table 45-3. New text, page 1110, table 45-3. So, yes, important. Go and take a look at that so you know the different cultures. It's just a handful of them. Important to know, though. Some of our assessment factors would be their albumin, pre-albumin, although those are not completely indicative of nutrition. They can kind of help guide us as to whether or not we think our patient is malnourished. More important would be nitrogen balance. It can be calculated to determine what those serum protein status is, and we know protein is very important for healing. Okay, dysphagia, yes, make sure you reference that page 1068, box 45-7 in your old text, and then on page 1115, box 45-7 in your new text. Okay, go and take a look at that. Aspiration precautions we've gone over several times, but always need to know that this is your old text on this slide. New text for your aspiration precautions. Hold on just a second. Taking a look right now. Page or skill actually is page 1130, skill 45-1 for your new text. Okay, so yeah, Make sure that we are verbally coaching them, no straws. We do encourage the patient to feed themselves. This makes them less likely to choke. And then thin liquids actually are more easily aspirated. Always, if you're ever unsure, you can ask if they can have speech consult for aspiration if we're worried about them, having issues swallowing. Okay, so this slide just talks about, here, the picture is just some of the tools that we might use for our patients when they have deficits and they're trying to maintain that independence and feed themselves. The important thing that I do want you to know on this page, it talks about, not necessarily, advancing diets. When it talks about advancing diets, please go to page 1074, that box 45-10 that talks about, that's your old text that talks about diet progression and therapeutic diets. Go ahead and reference that, and then in your new text, it would be 1122, box 45-10. You will get questions from that box, so make sure you understand those and what are some examples of foods in those. And then also don't forget about the honey or thick syrup or nectar thickened liquids. Honey thickened, anytime we're talking about honey thickened liquids, it's going to have that consistency of honey is what they're talking about there. And then if we're talking about nectar thickened liquids, it's going to have the consistency of like a buttermilk. Okay. Enteral tube feedings, we talked about that in lab. Just kind of go and refresh on those skills, all those yellow pages. Go back and refresh yourself on the steps of nasogastric tubes. Read this slide, obviously. Read all the slides that I'm doing in this review. Make sure you understand residuals. Remember, if it's 250, we're going to return it. If it's less than 250, we're going to return it. But if it's 250, we're going to recheck that in an hour. If in an hour we get another 250, we're going to notify that physician, hold the feeding, and just call him and say this is what's happening. Or remember, if we get that 500 at one residual check, then we're going to notify him or her. And then go back and take a look at that page that has the procedural guidelines. Box 45-13, page 1077 in your old text, and then it's actually, there's a procedural guideline 45-14, page 1125 in your new text, okay? Okay, so now let's talk about our urinary, chapter 46. This is an important chapter. If I were you, I'd go back and completely listen to this recorded lecture. I'm just hitting the highlights here, but it's got a lot of valuable information that you're going to see on this exam, and then also you're going to see on the HESI going forward. I would go ahead and just listen to that whole lecture there, but I just want to highlight some of this to pay ultra special attention to for this review for this exam. Go back and look at your definitions that come up in that lecture. Urinary retention. Urinary retention can be acute or chronic, and when we're talking about acute urinary retention, that should be considered a medical emergency. The patient's not able to void when the bladder is full or overfull. Okay. Chronic retention is when the bladder does not empty completely during voiding. This can lead to overflow incontinence, leakage of small amounts of urine. So what would you assess with this patient? Well, we're going to assess the bladder. Is it distended? We're going to palpate to see if it's distended. Ask the patient, when did they urinate last? Okay, so causes can be from neurological dysfunction, prostate enlargement, obstruction, or effects of certain medications can cause this. We're talking about urinary tract infection. most of those are typically caused by E. coli and may need antibiotics. If we're talking about that lower urinary tract infection, we're talking about burning, pain with urination, urgency, frequency, or maybe foul-smelling, cloudy urine. If we're talking about like a pyelo or an upper urinary tract infection, we're going to include fevers, chills, diaphoresis, and flank pain to those symptoms. Okay. Anytime we cath, by the way, a urinary tract, it is sterile, so don't forget about that. Common urinary elimination problems, please, please, please go back and take a look at all of these definitions. Again, it's covered really well in your recorded lecture that I did on this, but a table that's highly important, your old text is 46-1-1104, new text 1153, table 46-1 has all of those definitions on there. And, you know, what are they caused by? Like transient incontinency, that's caused by a medical condition that may be reversible. Okay, functional would be cognitive, sensory. Stress would be coughing, laughing, urge, at least on the way to the bathroom, those kind of things like that. And then reflex would be related to the spinal cord damage. But go and find out what those look like in detail. And then when we're talking about assessment, remember we want to know the characteristics. We want to follow intake, output, color, clarity, odor. These can all be indicative of different issues with our urinary tract system, our urinary tract system. Another procedural guidelines that I want to call your attention to, I'm looking for it in your new text right now. Okay, here it is. Old text would be box 46-11, page 1123. New text would be box 46-11, page 1172, using a bladder scanner. Please read this, know this. Very important that I call your attention to, if we are doing a bladder scan on a female that has had a hysterectomy, make sure that you switch it to the male identification when you're doing that. Laboratory testing, this would be, let's see, where was that? Diagnostic test that are on page 1113, table 46-5 in your old text, table 46-3, pages 1162, 1163. Those are some good areas to go back and take a look at as well for your diagnostic test.